for the training series on revenue cycle management. This is one out of 4 presentations, webinars on revenue cycle management. The schedule for the next 3 will be at the end of this presentation, and hopefully you registered for all 4. This particular training will focus on scheduling, pre-registration, point of service, and collection. Let's jump right into this. So my name is Boris Vilgorin. I'm the Healthcare Strategy Officer at MCTAC. Some of you might have seen me in the in-person presentation of revenue cycle management. The point of these presentations is now to take that in-person, which was a high-level overview, and dive a little deeper into specifics of each of those components of revenue cycle management that we'll be going through today. And again, for those who are newly joining us and haven't participated in MCTAC components, so MCTAC is the Managed Care Technical Assistance Center, and what we do is provide training, consultation, and educational resources to all mental health and substance use disorder providers in New York State. And our goal is to provide trainings and intensive support on quality improvement strategies, including business, organizational, and clinical practice, to achieve the overall goal of preparing and assisting providers with the transition to Medicaid managed care. So what is revenue cycle management? It's defined as all administrative and clinical functions that contribute to the capture, management, and collection of client service revenue. This describes the life cycle of a client account from creation to payment collection and resolution. The client account cycle is supported by a number of additional activities necessary to assure that all encounters are built, meet regulatory requirements, and revenue collection is maximized. So what I want to do is underscore a couple of main components here. One is that this is all administrative and clinical functions. This is important to understand. The revenue cycle management is not just a financial function. It is not just a billing function. It is really an all administrative and clinical functions, and includes everybody in the agency that might work with patients, clients, consumers directly, or even indirectly. And it's important to recognize that it's everybody's responsibility and not just one particular group within the agency. And so how's the revenue cycle management unique? I just started talking about the uniqueness of it. This is one of these areas of business functions where it does bring everybody together, or it should bring everybody together to work collaboratively. It's an interdependency and existence across non-natural occurring work groups. As we kind of know, we have our program folks and business folks and HR folks and so forth and so on. This really requires that everybody works together, and the revenue generation is, of course, the cornerstone of the fiscal viability. It also focuses on all the inefficiencies and errors and potential oversight that might have a devastating impact. So clearly, if the denial rates are very high, that's a big issue for agencies, especially with cash flow or in general even collecting revenue. And so clearly the clinical priorities and fiscal billing priorities are not always aligned, and it's important to make sure that those two are very much aligned and moving in the same direction. So here's the whole cycle of revenue. It starts with scheduling and pre-registration, and of course it goes through capturing the service, submitting claims, hopefully getting paid, and of course, if needed, an appeals, and then an analysis. Part of all of this, or what's included in revenue cycle management that's important to keep in mind, is there's the contract management components that will dictate some rules and requirements. There's quality assurance, just like with everything else. There's the utilization review. Utilization management is important. That requires authorizations and so forth that we'll talk about. And there's a credentialing component, making sure that the right individuals are providing the service, and of course an overarching regulatory compliance that's required. In today's presentation, we'll focus on the first two boxes of the revenue cycle management, and the other presentations will break out into pieces the whole revenue cycle management and focus there. So again, a different way to represent different phases. Some folks are more visual, some prefer words. So this is a different way to look at revenue cycle management. You can look at it as something that happens prior to the service, during the service, and then things that happen after the service, and of course, activities that happen ongoing throughout the whole cycle. So the first part in revenue cycle management, or the first part that happens, is somebody, meaning the client, the member, referral source, calls or faxes information. And member information needs to be obtained and recorded in whatever system you're using. It needs to be accurate. It needs to have minimum, of course, the name, the date of birth, the Medicaid ID number, the name of the managed care company. If a managed care company has a different ID number than the Medicaid, it's important to capture that as well, and of course the reason for calling. And all of this needs to be verified for previously registered individuals if somebody's calling back and it's a returning client, or definitely with a new client. So eligibility verification is a crucial component during the first phase. This is before anybody even gets to see the client. And so for the Medicaid population, we'll talk different ways the eligibility can be verified, but during that first contact, individuals who are obtaining that information should be knowledgeable about the insurance plans and coverages in your area. Different areas of New York State have different plans, so it's important to be very familiar with it, and of course having knowledge of how to verify that information. And in some instances, or actually in a lot of instances, the payers also have their own web portals or phone verification systems that could be used to call directly to the plan to verify that eligibility. And kind of the initial setup of the individual in the system with the right information on not just their name and date of birth and so forth, but their insurance become crucial, because any information that's inputted incorrectly later on, as you will see, creates a lot of problems, because that information just continues onto the clinical documentation, the services, and of course the billing, which later, after is discovered, needs to be reversed, which will take more effort and time and money to reverse than doing it right the first time, of course. So during the pre-registration process, depending on the service and depending if it's required and the plan, an authorization might need to be obtained. Some plans require clinical authorization, some don't. And again, the individual who's doing this should be knowledgeable, have some sort of a grid or information in front of them, to understand what the process might be, and if it's actually even required for a particular service. And just to be familiar with authorizations, when authorization is required, most authorizations will not only give you how many visits, but they also will give you a time or duration of the authorization, 3 months, 6 months, 2 weeks, whatever it might be. So it has two components. It has visits and authorizations. And in some instances, it might actually go down to the provider level, meaning that the authorization is for 10 visits for 3 months and for social worker, versus a different authorization that might be 6 visits for 6 months for psychiatrist and so forth. So it needs to be, again, the process and understanding the service, the plan, and the authorization process is very important. As a side note, as part of the managed care transition, both OMH and OASIS are working with all the plans to try to establish a standardized approach of which services will require authorizations, which don't. that is still being developed, and hopefully in the near future, when that becomes available, MCTAC will definitely be doing some of the technical assistance on it, and as it becomes available, the staff that are responsible for it should definitely participate in those trainings and learn those rules. After the initial information and authorization is gathered and the verification of insurance happened, usually what would happen is an initial appointment would be scheduled. Of course, if possible, the best way to do this would be through some sort of a centralized and electronic scheduling system, and that would be ideal, but if not, again, an appointment is usually scheduled. One of the components that's important to understand when scheduling the initial appointment, this is where the contracting and credentialing comes into place, is to understand the contracting rules in regards to how fast or how soon the individual needs to be seen. Most managed care contracts will stipulate on different levels of care on how fast that initial appointment needs to happen. And in some instances, they will stipulate, or depending on the service, you need to make sure that a right individual is scheduled for, meaning that, again, if it's a licensed social worker, that they actually are credentialed and appropriate to see this individual, not just for the service, but also for the managed care company, that they will recognize that individual and thus later on reimburse the agency for that service. It's a medical model, the whole scheduling component. There's efficiencies to be had there. You can, do some tracking in regards to how many folks have called, scheduled, have come in, have not come in, and of course tracking cancellation. But just want to again underscore understanding the contract and access requirement and credentialing is very important in making sure that the right information gets inputted and the right appointment gets scheduled with the right individual. At a point of service, so what that means is, so after all of this has happened, the appointment has been given, the individual shows up, hopefully shows up, for their appointment, which is referred to as point of service. There's additional information should be gained. One main reason is, depending on the duration of how long the time has lapsed between the registration and the individual coming in, one, information needs to be verified that was collected on the phone, and two, make sure it's complete. And of course, all the documentation that's like HIPAA and consent forms need to be signed. But again, in a lot of places, for customer services purposes and for efficiency, the telephonic information gathering might be very finite, very focused. And of course, when the individual comes in for their first appointment, additional information should be gathered, which, again, as I said, includes HIPAA, consent form, other forms, but also it's important to have some sort of a financial agreement in place, even for Medicaid individuals. So the individual who's coming into the program understands a potential financial obligation if they lose Medicaid, if they are, fee-for-service already and don't have any insurance, how the fees are collected, what would be their obligation, what are the policies, and then, of course, the responsibilities. Those are all important information that sometimes for the Medicaid individuals are bypassed, and at that moment it might be appropriate because they have insurance, they have Medicaid and so forth, but as we know, individuals change plans or lose insurance or lose Medicaid, and it's only fair and the right thing to do is to have a financial agreement in place. And of course, it's important to establish a process for no-shows in regards to what would happen if an individual misses a lot of appointments, and how do you even track no-shows. So part of the registration, and as I mentioned before, the eligibility should continue to be verified. So you have verification on the front end during registration, and definitely there should be some sort of a verification, either point of service or in some sort of an ongoing manner where your agency verifies eligibility. There's a number of methods to verify Medicaid eligibility. It could be done by telephone, something referred to as Verifone, e-Paces, which is right on the web. You can go through the internet. You would need to register to obtain e-Paces access. And then there's a batch upload. The most efficient way of doing this is really through the batch upload. And what that really means is that if you have an electronic health record or billing system or a clearinghouse that you use, what happens is the electronic system gathers all the information on a Medicaid recipient, either managed Medicaid, Medicare Medicaid, or straight Medicaid, and it could be done nightly, really during any time that you choose to set this up, where the system automatically or through some sort of a process sends information on all of active Medicaid clients in your system. During that process, e-Paces, eMedNey will go through that batch of all of those clients and return the information back to your system on the status of each client. So what that does is instead of checking one client at a time, and if you have 1,000 clients, doing that 1,000 times, you literally do this through your system. It could take a number of hours, but again, if it's done overnight or late hours, it's seamless, especially to the program, clinical, and even a lot of billing folks. Information comes back with all the eligibility status, including if anything has been changed, and you use then internal reports to determine and verify the status. That is especially very helpful for ongoing verification of eligibility, but it could be done for new clients and so forth. It does not mean that you have to choose one or the other out of all of these methods. You can implement all four and follow those, but I think it needs to be understood internally as the process gets established, who's verifying eligibility, at what point, are you using e-Paces, are you using batch uploads? If you're doing both, how often things get done, and who are responsible to do that. One of the issues I see as I talk to providers is the kind of cross-finger pointing of, I thought you were doing it, no, I thought you were doing it. And then at the end, of course, nobody's doing it. So those processes, procedures, workflows are crucial to establish, and especially eligibility with the population we're talking to could be fluid, as we know, and it's important to be on top of it, and a lot of times seems to be the main error or denial reason that providers experience. And of course, the information is as good as the Medicaid system, and we know some of the issues with that and some of the delays in information, but that is the best system we have currently. And so, and that's what everybody uses, so it's important that we continue as a provider community to use that. Collection. I'm not going to spend too much time on the collection of fees, since this applies really for individuals who don't have Medicaid, and as this transition and Sirius is really focusing on the Medicaid and Medicaid transition into managed care. But I think it's important to, again, to just talk about and mention collection fees, the process by which the fees are collected for the individuals, the sliding fee scales, deductibles, and so forth, needs to be established, needs to be upfront. The individual needs to understand, and the clinician and the individuals in the agency need to understand how this process works and who's responsible at what point. So what are the questions you should really be asking as it comes to this? And so one of them is, do you have the available capacity, time, and commitment from all the key stakeholders who may be involved in the change process. So that means that if you don't have revenue cycle management established now, is everybody on board in the agency? As I mentioned early on in the presentation, this is not just about one group of individuals, one department or unit. This is really the agency and everybody in the agency being part of this and on board. And do you have the right individuals and the right capacity? Is there an infrastructure system in place? Do you have an electronic health record, a billing record? Are those combined? Are they separate? Do you have any other systems in place to support this? Or is it all paper? And how would that work? Who will develop training materials and train staff? So, you know, we're doing some of the training. This is still a somewhat high level, but each agency needs to be able to take this information and develop more agency-specific training, their own policies and procedures, their own workflows. That needs to be taken out to the field. That needs to be taken out to the staff who actually do this, and training needs to be provided. Materials need to be developed. And, of course, just like with any training, this is not you know, a one-shot deal where you do it once and you no longer have to do this again. Things change, policies change, procedures change, staff change. And all of that, of course, needs to be taken into consideration. And the training individual or group needs to be designated. And when folks do have questions, because folks will have questions, cases will come up, who do they call? How do they get their answers to their questions? So this way, it comes from a central kind of area, somebody who's designated to answer questions, because we know that if in the lack of questions being answered, people will develop their own processes and procedures, and then as the years go by, the questions that become asked is, how does all of this work now? Who created this system, and who was responsible for all this? So having a designated staff that either answers the questions or goes to the right individuals who can answer questions is a crucial component. And has the revenue cycle, you know, team been identified and established? And if not, it's something you should look into and definitely consider. And there's always at the end, so there could be a team, but who is at the end is responsible for revenue cycle management. It's not the individual who everybody's going to blame when there's a lot of denials, but an individual who's responsible to truly bring the team together, make sure it's functioning, be on top of things, and really focus on the revenue cycle management. They might not know all of the aspects of it, but are the one who is, at the end of the day, is responsible, making sure that all components and all who's involved are participating and doing what needs to get done. As we continue with some of the questions, is there an ability to initiate significant organizational change? So we know change is difficult sometimes, or a lot of times, especially when it requires both structural and cultural change. So the question is there an ability? Do you need somebody to help along? Some agencies you know, find consultants or others to be helpful in such changes. And of course, again, keep reinforcing the need for interconnectivity and working together both between the clinical and financial operations, establishing policies and procedures. So this way it's clear how things operate, and a workflow. I think the policies and procedures and workflows, you know, work hand in hand in trying to really underscore and establish, you know, all the points of how revenue cycle management works, or any other types of policies and procedures. So just, you know, as I talk about workflows, just wanted to share a simple example of what a workflow might look like. Again, I think, you know, your agency really needs to sit down and develop their own particular workflows. So in this particular example, you have a member who calls for services. You know, staff obtains reasons for calling. and appropriate information. They decide is this an appropriate referral or not. If it's not, they would make referrals out. If it is an appropriate referral, staff will continue with the process, meaning obtaining additional information like demographic and insurance. If it's something that, if it's an insurance, for example, that the agency doesn't take, one option is to refer the individual back to the health plan to get another referral. If the insurance is acceptable, then the appointment is scheduled. So this is a very simple workflow. What I would strongly recommend when agencies develop such workflows, that actual names be put here instead of just word staff, because I've seen workflows with just staff being mentioned, and of course, nobody knows who the staff is, who's responsible for this particular box or particular decision. So putting names is very important. And then even blowing these workflows out maybe even further. When you get down to the appointment schedule, you might stipulate that appointment has to be scheduled within a week. And if not, a supervisor or manager needs to be contacted. If the referrals are being made out, how that gets developed and who the referrals go out. If there's any particular forms or fields in the EHR that needs to be filled out in any of these particular boxes, you can add that to the workflows. So a workflow could be as very simple as this to a more elaborate, workflow. And of course, it could reach a point where workflow is not helpful, where there's way too many errors and way too much information as well. So you have to really balance between making it friendly, usable, and when somebody picks it up, they understand it, and individuals can look at it and say, this is my box or this is my circle, that's what I'm responsible for, and this is how it all works. And it's a living document, just like a lot of other documents, just like policies and procedures. And of course, it needs to match and work together with the policy procedure and make sure that it's on the same page. One of my advices usually with the workflow is if there are too many errors that go all over the place, it's a good chance that a lot of folks are confused and it's probably a cumbersome process. So as a visual effect, sometimes just taking a quick look at it, seeing errors going all over the place, reconnecting or having errors to empty boxes might be a quick way to see where the issues are, gaps and inefficiencies. So I'm a big fan of workflows. Usually it's a painful process to establish one, but the end result is usually very helpful, both for the individuals and the agency. So as you think through the policies, procedures, think through the workflows, and try to figure out how do you put this together. One of the things that are going to come up is clearly the operational challenges and how would, one agency or you might think of addressing some of those operational challenges. Clearly, you need to start with articulating the measurable performance standards for all staff within the revenue cycle management process. So if you're referring to individuals who might be posting remittances or individuals who are doing registration, are there standards for them? Should they be on the phone X number of minutes? Should they be able to post X number of remittances? Do people understand how do they fit into the overall picture? Do they feel like they're just a siloed, isolated, that's all they do, they're not part of a bigger picture? And what are their responsibilities? I know some agencies are actually starting to put that directly into their job descriptions in regards to some of these measurable performance standards that are very specific into how many hours or how many of these or whatever these are the individual must meet. So this way, when somebody gets hired and handed a job description, it is clearly articulated in their job description. And, and of course, measure against them on a regular, and cycle. Because one thing we know is you can have a performance standard, but if nobody's looking, nobody's measuring over time, it kind of falls by the wayside, and people don't feel, and probably appropriate so, that they mean anything or it's worth even following. And when there are problems that staff bring up that especially affect their performance standards, it should be addressed quickly and effectively, and not just kind of lingered out there. Because again, individuals, what I find, and I like to believe, when they know what their measures are, they really try to meet those measures. And they will bring problems and issues to the table that address that, and it's important to address them quickly and effectively. Develop a clear workflow and point of responsibility, as I've stated before, and provide tools and information they need to succeed carefully, out their task. Not just, here you go, you got to do this with no additional information. So during my presentation, I talked about, staff being understanding what insurance the agency accepts or what insurances are available in a particular region. Why not put together maybe a tool or some sort of a information packet that might help staff guide through that? Or if it's a credentialing for a particular plan, why not have a tool that helps both the clinicians, the front desk, the registration person understand that? And of course, part of revenue cycle management, like anything else, should have a quality improvement process, quality control, and it should be ongoing. That looks at the processes, that looks and identifies inefficiencies and problems, looks where there might be issues, and tries to address all of that. And constantly, it's an ongoing process. And of course, it needs to assure that executive, clinical, and finance leadership are all on the same page and speak with a single voice, and not, it's not us and them situation where folks sit in the room and talk about, this is finance issue, this is not my problem, I'm just seeing clients, I'm just providing good service. Individuals and the leadership really need to be on the same page here. So here are some of the tools that could be helpful, especially if, with an EMR or EHR, with a strong billing component, electronic scheduling to maximize the use of clinical capacity, efficiently evaluate insurance eligibility, that would be part of the EMR and EHR, authorization tracking, knowing when something is expiring or needs to be obtained, and of course there's alerts that go out. There's the behind-the-scene management of charge capture, which means, documenting service and providing what codes or it should be built under, and coding and so forth. There might be services that are provided but unfortunately never actually left or were built due to errors. So it could be suspended claims that does not meet certain requirements. For example, if a treatment plan or a service plan is late, but a service was provided, that could be one of the reasons a service should not be going out. It has not gone out, but somebody should be really looking at it. Looking at, how do you post payments? Is it electronically posted? Is it somebody doing data entry? And again, provide reports that are necessary to address staff, system, and payer performance issues. Understanding overall how the system works. Are there particular staff that need additional training, additional support? Are there systems in place that might need to change to help out with a process altogether? And so, like with a lot of presentation, it's an obligatory, cartoon. And so one thing is just to keeping your eye on the money and how much you're spending versus how much you're getting, right? So we made $30,000 more last year, which is great, and it only cost us $60,000. I don't think any of us want to be in that situation. It's good to make more money, but if it's costing you more to make that, that's not good. So understanding your revenue and understanding how much it's costing is clearly an important factor here. So a couple of updates, just to make sure folks understand that the managed care organizations during this transition will be designating a billing contact per plan, and MCTAC is actually in a process of putting together a document that we're referring to as the matrix. It hopefully will be available later this week, where it will provide information on all managed care and contact information. We're starting with the contracting individual, and we will be expanding to the billing and other contacts by managed care. Again, it will be available on our website, and so look for that announcement, hopefully in the next couple of days or so. And of course, MCTAC will continue providing revenue cycle management workshops that will really focus on program and service specific needs as the services roll out in New York City starting October 1st and next year in the rest of the state. So here are the 4 revenue cycle management series that I was referring to. The next one is going to be charge capture and coding, followed by claim submission and payer, and then the last one is, of course, remittance process, appeals, collection, and analysis. And I believe the next slide will show the schedule. If you haven't registered for the next 3, strongly recommend that you do. They're all going to be from 12 to 1:30. At least that's the time we're putting aside. Want to make sure folks have enough time to ask questions, which I'll be doing shortly. And if you do have any questions, especially ahead of next presentations, we invite you to email them to mctac.info@nyu.edu. We monitor those and try to respond to them as quickly as possible. For these particular webinars, if you email it ahead of time, we'll make sure to cover them during the next presentation. And this is our information on just our website, and again, the questions in regards to where to send is in the previous slide. Let me just go back there. And so with that, I will finish the presentation and open the floor for questions. Just to let everybody know, this presentation will be posted in probably a couple of days and is being recorded as well on our website. And so just wanted to mention that and make sure folks have that information. And I will open for questions. If you have any questions, please feel free to text them, or I believe it's should be in your right-hand corner, any questions that you might have in regards to this presentation or revenue cycle management in general. So I'll just give a couple of minutes to have folks be an opportunity to write in their questions. Okay, let me start with, we have a first question. We are a walk-in clinic. We don't always have the chance to pre-cert clients prior to being seen. Any suggestion how to cut down on denials due to no pre-cert? That is a good question. It's a little more difficult with, of course, walk-in clinics. As individuals walk in, you want to serve them, of course, and not always sit there and wait for the authorization. My understanding, and you might want to check that with, I'm not sure if this is an OASIS or OMH clinic, that the first visits, at least in the Article 31 clinic that I'm familiar with, does not require an authorization. It is always good to have them, but they should be reimbursed. So hopefully those walk-ins are usually first visits. If it's ongoing walk-in, Of course, the authorization process is important, and as best as possible, getting somebody on the health plan side, the managed care side, to obtain that as soon as possible would be important. I would also suggest that you might want to talk to the plans you're dealing with, make sure they understand you have a walk-in clinic, and see if they're willing to work with you on being a little more lenient since it's such a great service where individuals could just walk in. But I think making the managed care aware of this, of your agency and your service, sometimes might help in the long run with some of the authorization issues. Okay. Well, thank you. Somebody wrote that this was great information. Thank you. Okay, let's see. Let's move on to the next question here. Okay, the Medicare clients sign an ABN at registration, but we have hard time collecting the patient responsibility during the course of treatment. Any suggestions? Yeah, collecting patient responsibility both for Medicare co-payments or self-pay, it is a challenge for probably every provider in the state. The suggestion, again, like I said before, you got to start with a clear explanation of the policy, of the responsibility. I think the individual needs to understand as they come in how much they owe, continuously how much they owe, making sure they understand. Sometimes working out a kind of a payment plan works for some of the individuals, but it does require, kind of a vigilant and ongoing process. As far as I know, there is no silver bullet to this answer, unfortunately. But what you can do is continuously make it clear to the individual of what the rules are, the policies are, and how they could, potentially pay for their responsibility. Okay, let's see if there's other questions here. From ATBS services, will MCO require pre-authorization in addition to the process of referral from health homes? That is still being developed by the state, both OMH and the OASIS. There's a potential, of course, for the authorization process. I am not sure if there will be one or if there's going to be, authorization for some services, but for not others. I am pretty sure for the crisis services, there won't be any pre-authorization requirements, but again, I would recommend that, hopefully in the near future, there'll be further guidance from the state, and as soon as we receive it, we will make sure to put it on our website, but at the same time, make sure to do a training on that. Can you tell me if case management will need to get prior auth? I'm assuming case management today usually means health home. I'm not familiar with requiring a prior auth. Have not heard anything about it, but of course, that doesn't mean that in the future that won't be the case. But at the moment, I have not heard anything in regards to case management requiring a prior auth. Okay, another question here is, do you anticipate any issue in obtaining eligibility information as Medicaid transition to managed care, managed Medicaid, and how can we plan for this? I don't anticipate any issues. I think EPACES, the way it's been continuing to work, is expected to continue to provide that information and provide the managed Medicaid information at this point. So it's just going to be more folks, more clients and consumers you're going to need to check on, but it should continue the same way it has worked prior to this managed care transition. See if there's any questions I might have missed. Okay, so I'll give it another minute because I think I covered the ones I got so far. see if there's any other questions that folks might have. All right. Well, again, let me just say thank you for participating this afternoon. This presentation will be, it has been recorded, will be posted. Give a couple of more days or so before you go to the MCTAC website. Let me just flip back to our website just in case you don't have that. And again, thank you, and look forward to the next couple of presentations. Take care.